Okay, it's about time for us to get started, so we'll go ahead and begin. We'll have some more members that'll be joining us, I think, as we go along. There are several other meetings going on and some things that conflicted, but they should be coming in. First of all, let me welcome everybody. Glad to have all you visit with us here today, and to our committee members here, Representative Sims and Gardner over here. Glad to have these folks. They've been here before, and Matt Hatchett is visiting with us today. Matt's a new representative, just elected this year for the first time, and wanted to come just sit in with us and visit with us today. So he's here too. So we're going to go ahead and get started. And what we'd like to do is let them make their presentation. At the end of their presentation, if we have questions, we'll entertain those questions, and we need to be out of here about 3:45. So with that said, we'll go ahead and begin with Cherry Tucker, Georgia Board of Physician Workforce. This one.
I'm Cherry Tucker, Executive Director of the Georgia Board for Physician Workforce and State Medical Education Board. First thing, we handed out some packets. There's a document called Annual Report Georgia Board for Physician Workforce. I'm just going to hit a few highlights in it. On page 1, the purpose of the Georgia Board for Physician Workforce is to address the physician workforce needs of Georgia communities through the support and development of medical education programs. And we have several powers and duties to locate and determine specific underserved areas of the state in which unmet quality needs exist for physicians by monitoring and evaluating the supply and distribution of physicians by specialty and geographical location. And then we approve and allocate state appropriations for family medicine training programs, including but not limited to fellowships in geriatrics and other needs that may be identified. Approve and allocate state appropriations for designated pediatric programs, and approve and allocate other state funds appropriated to the board to carry out its purposes. The board was originally established in 1976 as a special purpose board, the Joint Board of Family Practice, and in recognition of the broadened responsibilities, in 1998, we became the Georgia Board for Physician Workforce. On page 2 of this document, at the top of the page, the board is comprised of 15 members, 5 primary care physicians, 5 non-primary care physicians, 3 hospital representatives, including 1 rural hospital representative, 1 business community representative, and 1 consumer member with no connection to the practice of medicine. Members are appointed by the governor and confirmed by the Senate for 6-year terms. The board also created a medical education advisory committee in 1997 to advise the board on medical education and physician workforce issues. It's the only forum of its kind in the state and brings together medical education leaders on a regular basis. It's comprised of deans of the medical schools and their designee, as well as hospital CEOs from each of Georgia's teaching hospitals. We have 6 staff members, and we also support the State Medical Education Board. We're 100% state funds, and for fiscal year 2010, our expenditures totaled $42 million. On page 3, Over the last 5 years, legislators and programmatic leaders from 2 states, Florida and New Jersey, have contacted the board to learn more about what we do and so they could build upon it. Reasons cited for this were the Georgia Board was a recognized leader of physician workforce analysis, the experience we had with GME new program development, working relationships we had with public and private medical schools and teaching hospitals in the state, and efforts to promote stewardship and ensure accountability of state funds. Our programs we have start on page 4 of this document. We have what we call our undergraduate medical education programs, which are medical schools. And we have a medical school operating grant with Mercer University School of Medicine, and we contract with them as a means of increasing the supply of primary care physicians in Georgia. The mission of that school is to educate physicians and health professionals to meet the primary care and health care needs of rural or medically underserved areas in Georgia. And during the 5-year period from FY 2006 to FY 2010, 58% of Mercer's graduates entered a primary care or core specialty based on the definition from the Georgia Board in our contracts. 62% of Mercer's alumni in practice as of June 30th, 2010 are practicing in Georgia. And there's a map toward the end of the document with their locations. The board also contracts with Morehouse School of Medicine as a way of increasing primary care and underrepresented minority physicians. Morehouse concentrates its efforts on training primary care physicians in order to address the disproportionate shortage of health care resources in poor and minority communities. During the 5-year period of 2006 to 2010, 71% of Morehouse graduates entered a core specialty residency program, and 47% of Morehouse alumni are in practice in the state of Georgia. There's a map of their location at the end of the document as well. Page 5, our other undergraduate medical education program is called Medical Student Capitation, and we provide funds to Mercer, Morehouse, and Emory to train a certain number of Georgia residents in their medical schools. The capitation rate for 2010 was approximately $7,800 per student. The contracts stipulate, as the medical school operating grant contracts stipulate, that at least 50% of their graduates enter a primary care core specialty residency program. And over the last 5 years, the rate of graduates entering primary care core specialties for all 3 schools combined was 56.5%. The next program of the Physician Workforce Board is the Graduate Medical Education Program. And through this program, we fund residents in training, physicians in training in several different specialties. Family medicine residency capitation, we fund approximately 204 residents or contract numbers, and over the last 5 years, 65% of their graduates have remained in state to practice. In fiscal year 2010, funding was provided for a total of 197 residents at an annual capitation rate of $20,260 per resident. And there are 10 family medicine residency programs strategically located throughout the state. In '96, the General Assembly provided funds for pediatric residency capitation at the Medical Center of Central Georgia in Macon and Memorial Health in Savannah. And this was to address the need for pediatricians in Middle and South Georgia. Over the last 5 years, 56% of the graduates from those programs have remained in Georgia to practice. And about 5 or 6 years ago, I believe, we also added funds to the pediatric program at Morehouse School of Medicine. In fiscal year 2010, we provided funding for a total of 50 pediatric residents at an annual capitation rate of $16,692. We also provide funding for preventive medicine residency capitation. In fiscal year 2010, We funded 7.5 residents at the two programs at Emory University School of Medicine and Morehouse School of Medicine at a rate of $8,150 per resident. And over the last 5 years, 56% of their graduates have remained in state to practice. In fiscal year 2009, funds were provided in our budget for the expansion of the general surgery program in Macon and the OB/GYN program in Savannah. That capitation rate is $16,522 per resident, and we fund up to 4 residents in Macon and 2 OB residents in Savannah, and this was the expansion of their programs. The final GME program we have is residency capitation, and this provides funding to public and designated teaching hospitals in recognition of their commitment to training physicians for Georgia and to help offset that cost of the sponsored medical education programs. It's not limited to primary care. It provides funding for all residents in training of all specialties. The rate is based on the annual appropriation divided by the actual number of residents in training. And over the last 5 years, approximately 60% of the graduates in these programs have remained in Georgia to practice. In 2010, we provided funding for approximately 1,154 residents at an annual capitation rate of $3,003 per resident. And then the last few pages in the document are the maps, location of the programs, a chart of the funding provided to each hospital and by which grant or medical school, and then the alumni and practice maps for Mercer and Morehouse. Also in your packet, I'm not going to go over each one of these, and I hope you will read these. These are letters of impact statements from the teaching hospitals and medical schools of what these additional cuts, the possible impact on training of the physicians in Georgia. They're talking about the impacts could reduce the number of physicians being trained, possibly halting the expansion of the medical schools and residency programs, reduction in clinical medicine course offerings. Each individual program, there's different impacts in the reductions of funding for those. So those letters, copies of those letters are in your packet. There's also a couple of sheets that Mercer asked us to provide to you on the residency selection of their graduates, as well as their residents, their graduates in practice on that. And in going over the tracking sheet for the FY11 amended budget, governor's recommendations, 17.21 is where the Georgia Board starts, Georgia Board Administration. 1721.1 reflect an adjustment in telecommunication expenses, a reduction of 5,754. 1721.2 is a reduction in personal services, 10,729. 17.22, graduate medical education, is a reduction in funds for the graduate medical education programs. Each individual program, as you heard, they're all capitated at a different rate, but the overall reduction is $336,943. 17.23, Mercer School of Medicine operating grant. Reduced funds for the operating grant, $1.3 million. That's a 6.1% reduction. Morehouse School of Medicine, 17.24. In their operating grant, this is reflects reduced ARA federal matching assistance percentage funds and replaced with state funds. This is an increase of $690,703. Their state funds were reduced 2 years ago because of the ARA money they received on their matching funds. And in 17.25, Morehouse did approach the board and ask us to take, instead of taking their 6.1% reduction out of their operating grant in order to maximize the federal dollars, they asked the board to submit in the budget request to take that 6% out of their medical student capitation funding. And in 17.25, that $493,914 is the 6.1% reduction to Morehouse, and then reduced funds for medical education, Georgia residents in private in-state schools, $124,260 is Mercer and Emory's reduction, and that's all for the Physician Workforce Board.
Do we have any questions from the committee? Representative Garner.
Thank you very much, Mr. Chairman, and thank you for trying to bolster our medical education workforce. Do you have the, I think we're all interested in the number of the physicians and residents that stay in Georgia, and do you have any breakdown by medical school? I noticed you have, of all the medical schools, 56%. And I'm not asking you to give it to us now, but could you provide by individual medical school for me?
We will.
Thank you.
Okay. Any other questions? Ben? Dr. Watson? Let's see, 17.
Thank you, Mr. Chairman. It's my understanding that we produce about 400, or we have about 400 residency spots, and yet our medical schools in the state of Georgia have about 500 or so medical students. Aren't those about the right rough numbers? The reason I bring that up, the way I understand it, is we have about 100 slots of residents. I should say we're producing more students, around 500, and yet our residency spots in the state of Georgia is around 400. And the reason I bring that up is that most residents and physicians will practice generally within 100 miles of where they do their residency. I'm not here in these tough economic times saying that we need to spend more money here, but I think that's something that that deserves attention in the future.
Okay.
Thank you.
I'm not sure that we brought that with us today, but I will get that information to you.
Okay. Any other questions, comments from the committee? Jerry, thank you.
Okay. Let me.
You got your other part there? Okay.
Right. The other board that the staff works for is the State Medical Education Board. You also have a smaller annual report for 2010 on the State Med Board. The purpose of the State Med Board is to recruit physicians to rural communities throughout the state. Specifically, the board helps bring about an adequate supply of primary care and other needed physician specialties in rural Georgia by providing medical education scholarships and loan repayment opportunities for medical students and licensed practicing physicians willing to practice in a targeted rural community. The State Med Board was created in 1952, and Georgia was among the first states to establish a scholarship for rural physicians. It's now entering its 59th year and is the longest standing program of its kind in the country, and has served as a model for other states and also the federal government. The board consists of 7 members appointed by the governor, and there are 4 staff positions, and as with the Georgia board, the staff works together for both agencies. There are basically 3 programs of the board. The Country Doctor Scholarship Program provides up to $20,000 per year in tuition support for Georgia residents attending medical school in the U.S. They are required to practice in a Georgia county of 35,000 or fewer people after completing their medical education, and 1 year of service is required for each year of tuition support, which is usually a 4-year commitment. In fiscal year 2010, 26 scholarships were funded, down from 30 in 2009. 16 were renewals and 10 were first-time awards. In 2010, 7 scholarship recipients began practice in a rural area, and 13 physicians have indicated they will begin practice in rural Georgia during fiscal year 2011. The most recent scholarship recipient data collected over a 5-year span shows that 85% of the scholarship recipients remained in Georgia to practice after completing their service obligation. 47% remained in rural Georgia, and 75% of those who remained in Georgia are practicing primary care. Our Physicians for Rural Areas Assistant Loan Repayment Program offers up to $25,000 per year in student loan debt for physicians who agree to practice in rural, medically underserved Georgia communities. It's comprised of state dollars only. They must agree to practice in a county with a population of 35,000 or less, according to the census of 2000, which this year's contracts will reflect the census of 2010. They may be performed in for-profit situations, and scholarship recipients can participate with an extended service commitment. Maximum funding is 4 years for up to $100,000. In fiscal year 2010, there were 29 applicants for the program, down from 40 applicants in 2009. 17 physicians received loan repayment through the program in 2010, and in 2009, 22 physicians received the loan repayment program. This year, because of the budget reductions in the scholarship program and the loan repayment program, we had 33 applicants and were only able to make 7 awards. The Georgia Medical Fair was established in '79 to provide a low, cost-effective way for rural communities to recruit physicians to their communities. We usually have 30 to 40 rural communities come together and have anywhere from 75 to 100 resident physicians or physicians in practice. Over 400 physicians have been recruited to rural Georgia with the help of the medical fair. The most recent statistics show that 89% of the physician attendees indicated an increased interest in rural Georgia after attending the fair. 71% who attended the fair remained in Georgia to practice, and of that 71%, 31% currently practice in a rural Georgia county. And 82% of the physicians who attended the medical fair went on to practice in a primary care specialty. The governor's budget recommendations for the State Medical Education Board are found under 17.28. There's an increase, 17.281, reflect an adjustment in telecommunications, an increase of $7,000. 17.282, reduce funds for personal services, $6,080. 17.283, reduce funds for medical scholarship program, $20,000. That is one full scholarship. 17.284, reduce funds for the loan repayment program, $10,000. That keeps us from making one award. And 17.285, reduce funds for the medical fair, $5,728.
Okay, thank you. Any questions or comments from the committee? Well, you did a good job explaining this, looks like, Jerry. Thank you.
Thank you.
Next, we're going to hear from LaSharon Hughes with the Composite Medical Board. Who's next?
Mr. Chairman, members of the committee, LaSharon Hughes, the executive director, could not make it today. She's recuperating from surgery, but she's recuperating very well. So
good.
We expect her back in the office probably next week. And in the meantime, I'll present to you the amended fiscal year 2011 recommendations. We decided not to bring a printed presentation for you and hold off on that until the fiscal year 12 because we saw that we had 10 minutes and didn't want to bog you down. But I'll tell you very quickly the program purpose of the Georgia Composite Medical Board, which is to issue licenses to qualified applicants in more than 10 medical professions. We have approximately 41,000 licensees as of December 30th. We also regulate the professional practice of these professions by promulgating rules to establish baseline practice and conduct standards for each profession. And we guard patient safety by investigating complaints against licensees and disciplining those who violate the Medical Practice Act and the rules and laws that are associated with that. I'll go straight to the governor's recommendations. We'll start on 17.26. Point 1, reflect an adjustment in telecommunications expenses of $36,928, and what that does. Sorry, I'm finally getting to that age where I actually have to have these now. Absolutely.
I apologize. We're having some technical difficulties. We're trying to get that work done, but we ain't got it corrected yet.
Absolutely. Here we go. So 17.26.1, increase funds for telecommunications expenses in the amount of $36,928. And that addition is simply to essentially true up the budget with the bills that we get from the IT consolidation and privatization. That's simply to get it back up to the actual expense that we're billed by GTA. 17.26.2, reduce funds for personal services, $70,007, and regular operating expenses, $69,27. I'll take the personal services issue first. What we've done is we postponed filling a medical board agent position that was vacated in November of 2009. We anticipated, of course, as everyone did, that there would be a need for budget reductions. So we made a decision to wait to fill that vacancy in anticipation of the budget cut. Obviously, that puts us one enforcement agent down. However, we made the decision that was probably where we could best take that hit at the moment. Reduce funds for operating expenses in the amount of $6,927. Again, we anticipated that there would be a reduction. So as many of you probably recall, we raised certain of our fees last year. The fee that was raised in anticipation of this was to increase the fees on wall certificates. Those are the certificates that look like diplomas that you've seen in your doctor's offices, and well, as you know, probably the pharmacy board issues something that's very much like that. And so we raised the fees on that in order to replace the funds that we're giving back to the general fund in regular operating expenses.
Okay, Bob. Thank you. Any questions or comments from the members of the committee? Michelle, Representative Henson, 25.
How much are the fees now for the certificates?
For the physicians, Representative Henson, the fee is $50, and for the non-physicians, it's $25. The physicians get a much bigger one, and the non-physicians get a smaller one. And that's just tradition. That's.
So we have been charging all along something?
We've been charging for replacements. Now what we do is we no longer simply hand it to you once we issue your license. If you desire to have it, then you order it and pay the what used to be the replacement cost.
Do other boards charge for those?
Yes, they do.
Okay, I just didn't know. I just wondered. Thank you.
Okay, Bob. Thank you very much.
Thank you.
Next, we'll ask Mr. Bill Todd to come up and talk to us about the Georgia Cancer Coalition.
Thank you, Mr. Chairman. I'm Bill Todd, Director of the Georgia Cancer Coalition. I'm joined by Alan Wills, our Chief Financial Officer. You'll find us on page 72 of the tracking documents, section 40.22, and you have a printed form that I'll speak mostly from that's light blue and green. Our mission, of course, is to reduce the number of deaths due to cancer and to make Georgia a leading state in the nation in cancer care. And I'm pleased to tell you that after 9 years of investing in the Georgia Cancer Coalition, the strategy is indeed working by any measure. The one that matters the most is deaths. When we began, we were poorer than the national average in deaths per 100,000. We have caught the national average, and now we are surpassed the national average. Bottom line on that is that 150 Georgians are still with us each year. We really have two prongs. We want to zealously implement what we know about cancer. American Cancer Society suggests that half of cancer can be prevented, and to passionately discover what we don't know about cancer. We will operate across the continuum from prevention all the way to palliative care with programs and people and initiatives. This year I'd like to emphasize, Mr. Chairman, the phrase that we hear frequently, doing well by doing good. It's always been part of our program, but it has come to the point of maturation where we can really begin to harvest some of those benefits. And there are four main ways that we can do well. Care for Georgia cancer cases in Georgia, as opposed to them going somewhere else. It's better for the patient. It's better for our economy. Form new startup companies from the research emanating from the laboratories. That's a classic Silicon Valley technique. It's the slowest, but it potentially has the greatest return. Attracting pharmaceutical and biotechnology companies from other places because they want to be around the brain trust of the scholars that we have recruited at our research universities and medical schools and community hospitals participating. And then grow the federal research funding. We have one of the steepest upward curves in research funding in the nation from the National Cancer Institute, and that's directly related to this strategy of recruiting top talent from the best cancer centers in America to come to Georgia to our institutions. So there's a direct correlation. 40,000 times this year and every year, someone will hear those terrible words, "I'm sorry, but you have cancer." 4,400 times each year, we will hear the patient or their family say, "Doctor, I'll go wherever I need to find a cure." And it's that phenomenon that we really would like to focus on. Healthcare is the largest employer in many of our communities, Savannah, Albany, Thomasville, Columbus, Rome, and others, and it's growing. I just came from a presentation by the economist Jeffrey Rosenzweig at Atlanta Rotary, and he showed trend lines in all levels of employment, and healthcare was the only one that was continuing to rise during the recession. If we look at our neighboring state of Alabama, they have 8% in-migration. In other words, people come from other states, including Georgia, to Alabama. They have 2% out-migration, some of their patients leaving, going to Sloan Kettering or MD Anderson, for a net 6% inflow. So that means that they are engaged in what can be called medical tourism or an economic sector called cancer care. The General Assembly is well familiar with the strategy of CTCA, Cancer Treatment Centers of America. They built their whole program around attracting people to come from other states to use the benefits of Hartsfield Airport, and they're in the business of building their center in Noonan so that they can take care of people who come into our state specifically and solely for their cancer care. Well, the economic opportunity is significant. If we were coming to you with a plant that said we would do $154 million of sales a year, I think you would all be interested, and that's really what we're leaving on the table at 4,400 cases per year. If we were able to retain those and just get back to zero, we would hire more doctors, more nurses, more support staff, and realize some of the benefits of being an in-migration, import state in cancer care. One can imagine sometime during the next 10-year period that we, in fact, would be a destination site like CTCA has envisioned in places all around our state, not just the one using Hartsfield Airport, especially in our border communities like Rome and Augusta, Savannah, Thomasville, Albany, Columbus, and Rome. And that is a realistic technique if we keep our foot on the accelerator. We indeed are moving to national leadership positions. Emory, finally, after all these years, was designated by the National Cancer Institute as one of the 62 designated centers throughout the country. This is the backbone of the NCI strategy, and we were missing in action until April of 2009. Conversely, we have 2 of the only 30 National Cancer Institute community cancer centers. This is a new program to bring the benefits of cancer research to community hospitals, and we have 2, one in Savannah and one in Sandy Springs. There have been 9 new cancer centers constructed at hospitals all over the state, funded in hundreds of millions of dollars by the private sector. This is in response to Georgia getting in the game in 2001. We have the state's first clinical trials network, which is an important component in getting the benefits of the research to the patient at their hospital. The director of the CDC has designated us as the top tier of a cancer control plan. Some 150 Georgians come together on a regular basis to hash out what we should do, and we follow that Bible. And we have the benefit of it being the headquarters of the American Cancer Society and the CDC, and we're increasingly seeking to take advantage of that. The primary part of our investment strategy is importing this talent, as I mentioned. We call them distinguished cancer clinician and scientists, and the amended budget calls for a reduction of $385,000, as you'll see in 40.22.1. That equates to about three scientists or clinicians who will not be recruited. We did have plans to expand the program. For the last few years, we've been moving some of these scholars out of the medical schools and research universities and having them in community settings. There are 7 so far in Savannah, Albany, Columbus, Rome, Sandy Springs, Decatur, and did I say Rome? And Rome. So 7, and these folks who have appointments at one of the other medical schools are the linchpin of us getting clinical trials. They're conducting clinical research in collaboration with one of the medical schools where the discoveries are being made. So we'll not expand that program this year, but fortunately this budget does enable us to maintain our commitments for these 5-year grants to these institutions. The biorepository is, of course, the mechanism by which medicine of the future will be managed, where every patient's DNA will be known and every patient will have chemotherapy based on that DNA, in other words, customized. So we will not have an expansion of that program this year. Our clinical trials initiative will slow down. We had made some good progress with the GYN oncology trials. We'll have to suspend those. Last year we had 22 trials for GYN cancer. The Regional Cancer Coalitions of Georgia is one of the most popular programs that we have in the General Assembly, and rightfully so. It's a unique opportunity to get to the grassroots at our communities all over the states and involve hundreds of people in this process, primarily in education, screenings, community outreach, and the impact of this reduction of 6% will be less of all those. Our operations, we will reduce by $73,000. We had planned and budgeted in our submission for a statewide cancer summit to mark the 10 years. It's a way to get people energized and more involved. We'll not be able to do that. And we really wanted to get more qualitative data about the migration phenomenon. We really wanted to know why people were saying, "I'll go wherever," and then doing it, why 4,400 people do. We believe, and we'd like to see this validated, that our reputation lags our capabilities, and people are going on old reputations rather than the current one. I'll be glad to answer any questions, Mr. Chairman.
Okay. Do we have any questions, Mr. Ty? Okay. Representative Stevens, 24. Gotcha.
Thank you, Mr. Chairman. Bill, the commissioner is sitting right behind you there. Last year they told us that the department spends $500 million a year in health care-related illnesses as a result of cigarettes. You got an opinion?
Yes, sir. The data are very clear about that tobacco is the leading cause of death from cancer. It is 85 to 90% of all lung cancer, which is the most devastating and the leading diagnosis in the cancer world. And much of this improvement that we've seen have come from smoking cessation programs in partnership with the Department of Community Health and especially with the regional coalitions at the grassroots level. So yes, sir, the data are very clear about that.
Thank you. Representative Gardner.
Thank you very much, Mr. Chairman. I am really proud of the work that you've been able to do with the centers. I keep trying to follow your budget, however. And each year it seems like we find your budget in some new place. Can you give me a little description of why you are? I mean, some of your budget is in the community health, some in the Board of Regents, and now it's going somewhere else.
Well, this budget is in the Board of Regents. There is a generous support for programs in screening, colorectal screening, and breast and cervical cancer screening in the Department of Community Health. Okay. It's been that way from the beginning.
Okay.
The previous chairman had some challenges with that because he had to go all over the place. We made some progress in aggregating some of it, at least on the same page. In order to get a real picture of how much we're investing in cancer, not counting the treatment for not controlling cancer, the best place to look is the summary of the use of tobacco funds. You'll see all the uses on that page. And Margie, I'm not sure you want to point that out.
Okay.
Okay. Any other questions? Dr. Watson.
I noted the Alabama numbers, in-migration, out-migration. Do you have those for Georgia?
Well, it's 11% out-migration. We don't have the in-migration. That's part of the study we would like to do. But we believe that that is a net number. And we got that by doing a study of the State Health Benefit Plan where we can get claims data in cooperation with DCH, blinded, anonymous claims data. That's not a perfect approximation of this population because the people who say, I'll go wherever I need to find a cure, usually are blessed with the financial resources to do this. These are not Medicaid or uncompensated care patients. These are people who are fully insured and have discretionary income to fly to Houston, stay in hotels for the duration of their treatment. But we are anxious to find a better number, but the approximation of 11% is pretty good.
Okay. Any other? Thank you, Bill.
Thank you, Mr.
Thanks
Chairman.
for being here. Okay, next we're going to hear from Commissioner Cook in the Department of Community Health.
Mr. Chairman. Take just one sec to get we up and running. Good. Thank you, Chairman Parrish. It's a pleasure to be in front of you today to present the Governor's amended FY11 budget for the Department of Community Health. Members of the Appropriations Committee, pleasure to be here with you today. I had some opening comments that I gave on Thursday, and I'm not going to repeat what I had to say on Thursday, but I do want to underscore a few brief points for you. First, let me just indicate to you that it's really an honor for me to serve as the DCH Commissioner, and I'm really excited about being part of DCH. And as those of you who know me know, I believe in the DCH mission, and I look forward to working with you and other members of the General Assembly on these appropriations. Just like Georgia, DCH has a number of challenges that we face, and I have been indicating wherever I talked that there are several things that I would like to see in terms of basic communications from DCH. DCH will be a good listener We'll always seek to understand what people have to raise in terms of concerns and address those. DCH intends to be a good partner with the provider community and with our vendors, and we want to work with the citizens of the state of Georgia. And finally, DCH needs to be and will be a good steward of the funds that you all appropriate. I have with me, sitting next to me, is Vince Harris, who's the Director of Finance for DCH. Scott Frederick King is here, and several other members of the staff that I may call on to answer some specific questions that you may have today. As you know, DCH is a large agency for health planning and purchasing in the state of Georgia. It's designated as a single state agency for Medicaid and the state health benefit plan, and both of those combined cover approximately 1/4 of Georgia's population. And as you also know, in 2009, the General Assembly moved health facility regulation, public health, and emergency preparedness over to DCH, which substantially increased the breadth and scope of the operations of the department. The first slide, and do you all have handouts too? Yeah. The first slide has to do with the 7 basic program areas within DCH, and as you can see from this, there's a snapshot of the state funds in the budget. As you can see, age-blinded disabled population makes up nearly half of our budget, with over a third dedicated to the low-income Medicaid population. Public health makes up about 10%, Peach Care about 3% of our budget, and administration is approximately 4%, with health facility regulation coming in at less than 1%. The presentation that we prepared for you today tracks in 2 ways. I guess it's the governor's budget document, which are items on the left side that you can see there, but also the tracking sheet references in the far right column. So, for example, in the first category that I'd like to discuss is the Department Administration. Item number 1 is to provide for an adjustment in workers' compensation premiums, and you can see that as $42,000 increase for that, and that's found on page 24, and it's tracking item 17.4.1. So you can follow along on your tracking document also by referencing the slide there as well. I'll just go through these. Item number 2 is a reflection in the adjustment of telecommunications expenses, and that is an adjustment requested by the Georgia Technology Authority and Georgia Enterprise Technology Services for billing for telecommunications. Item number 3 is a transfer of state funds related to the Department of Human Resources reorganization of public health, and that is a telecommunications and software licensing budget item of about $2.5 million. Item number 4 is the transfer of low-income Medicaid funds to the finalizing the Medicaid Management Information System. We have converted very successfully to new MMIS vendor. Until that system is certified, however, we can only receive a 50% federal match of those funds for the system. Once the system is certified, that match goes up to a 75% match, and we hope to have that done, I believe, in November or towards the end of this year. MMIS implementation, I have to say, has been one of the more successful in the country, and certainly much, much better than the last go-round several years ago. Item number 6, to replace state general funds with federal funds for nursing home eligibility online reprocessing in the amount of a $200,000 decrease. And item number 7 is to reduce funds reflecting saving from space consolidation over at 2 Peachtree, where our headquarters office is, where we've consolidated some office space and will not be paying rent on some of the office space that we have there. Item number 8 is to reduce funds for personal services, which is keeping vacant staff positions open. Again, that's on page 25, item 17.48. Item number 9 is to reduce funds for computer contracts to reflect savings related to the transition of our new MMIS project. As you can see, there is a 13.8% increase related to that, primarily related to the MMIS conversion. Moving on to the adolescent and adult health promotion program metrics. You can see some of these metrics there. We do provide services in communities throughout Georgia for adolescent health, about 30 program sites located in 27 counties. They're strategically located in areas where there's a high school dropout rate and teen pregnancy rates are amongst the highest. As you can see, we do a number of cancer screenings, over 16,000 mammographies, over 74,000 pap tests, and we have the tobacco quit line, which relates to tobacco cessation programming. If you look on the budget document, page 24 again, you can see that we again reduce funds for personal services in this area of about $174,000, and we do associated operating expenses of about $365,000. Item number 3, we realign TANF funds based on prior year expenditure. That's just a note there that that's what we're doing with regard to the budget. Number 4 is a swap of tobacco funds, replacing state general funds with tobacco settlement funds in the amount of $87,000. Item number 5 is to reclassify other funds as federal funds in accordance with the Office of Financial Management Policies and Procedures. That amount doesn't have an amount associated with it, but that's a budgetary item. Number 6, reduce the programmatic grant and aid to county boards of health in the amount of $23,500 approximately. Those are program funding for specific programs, which is distinguished from the formula, which is the administrative support that we provide to counties across the state. The next area is adult essential health treatment services. Again, this relates to program areas where we provide cancer treatments, about 2,200 cancer treatment services to over 360 clients statewide. We provide well over 14,000 clients with stroke and heart attack prevention services, and we're projecting another 14,000 receiving those services in FY 2011. In the budget document, item number 1, again, there's a replacing state funds with tobacco funds of $138,000. Item number 2 is to recognize contract savings from moving the high-cost hemophilia clients into the new federal pre-existing condition insurance plan. We've been working with Hemophilia of Georgia on that. They've been working to move patients without insurance to the new program, the PSIP program, which is a Federal Department of Health and Human Services program. And this is only being done where there's total insurance costs that would be less than the medication costs that we provide. I want to thank Hemophilia of Georgia for their work in this area. The next program area is emergency preparedness. Obviously, that is preparing for natural disasters, bioterrorism, and other emergencies, as well as improving the capacity for the state trauma system. Primary goal is to assure a regional and statewide response to healthcare crises. We have 14 regional coordinating hospitals that have developed crisis standards of care related to that. With regard to the funding in this area, you can see that in FY11 the budget is decreased by $377,000 related to payments to trauma centers to maintain their trauma registries. The next area is epidemiology. A very important part of what we do in public health, conduct surveillance of notifiable diseases and conditions. We've tracked more than 75 this year. We investigated 171 events of public health significance, of which 102 were confirmed as disease outbreaks. And of course, the major ones in that area were the norovirus, salmonella, and influenza. If you look on the budget document, page 25, item 17.6.1, we discontinue the laboratory testing that's available through the private sector. There are 3 areas of lab tests that are available through the private sector that are being discontinued: well water testing, fluoride testing, and AIDS testing. And in this particular area, I believe this relates to the HIV testing, which is reduced by almost $14,000. Item number 2 is a reduced programmatic grant and aid to county boards of health by approximately $84,000. Item number 3, reduced funds for the Georgia Poison Control Center of about $51,000. And again, item number 4, you can see where we don't replace or fill vacant positions within the department, saving approximately $104,000. The next area I'd like to touch on is health care access and improvement. This is an area where grants are provided and other support services are provided for programs that seek to improve health access and outcomes in the rural and other underserved parts of Georgia. We have our State Office of Rural Health that's engaged in this, and the Office of Health Improvement. This is as well the area where we operate the Certificate of Need function. If you look at item 1, which is on page 25, 17.7.1, you can see, again, a reflection in the workers' comp premium. And item number 2 is a reduction of funds for the area health education centers. The AHEC network is a health professions workforce program that provides information and services to students and other health care providers. The next area I'd like to touch on is the healthcare facility regulation area. Some interesting program metrics there. Over 14,000 active facilities are licensed or certified by the department. There are almost 3,000 inspections completed in 2010, but as you can imagine, not all facilities are inspected annually. We process more than 7,000 incidents and about 2,500 complaints related to licensed healthcare providers through this department. Health facilities regulation in the budget, item number 1, we reduce expenditures by approximately $90,000 related to adult daycare licensure. Item number 2 is to reduce state funds for the 6 new licensed positions that were provided in the FY11 budget, and those are positions that were appropriated last year but are not projected to be filled this year. The next area relates to immunizations. We provide nearly 2.5 million immunizations in FY 2010. On the graph there you can see the number of immunizations that are provided, and obviously a very important function of what we do. In the FY11 budget, you can see a reduction of $1.8 million. That relates to federal stimulus funds that are available to be drawn down to purchase those vaccines, and so essentially what we're doing is replacing state dollars with federal stimulus dollars in this program, or in this area. The next area is the Indigent Care Trust Fund program area. This is a program that supports rural and other healthcare providers, primarily hospitals, that serve medically indigent patients. The Disproportionate Share Hospital Program is a federal program that allows for an adjusted payment to hospitals that serve a significantly disproportionate number of low-income and uninsured patients. And in order for the state to participate in that program and receive federal funds, all hospitals must meet the federal requirements as to the Disproportionate Share Hospital program, and those are also known as the deemed hospitals. In the budget area, you can see that we provide $7.8 million for this particular program, and that allows us to draw down more than $200 million in federal matching funds. The next area is infectious disease control. Obviously, the purpose is to ensure the quality prevention and treatment of HIV, AIDS, sexually transmitted diseases, tuberculosis, and other infectious diseases. You can see some of the metrics there: 16,000 risk reduction sessions, 139,000 HIV tests conducted, and other services provided in this area. There's only one line item in this area of the budget, item number 1. It's about $269,000, and again, that is related to the discontinuation of lab tests related to HIV in this area. The next area is infant and child essential health treatment services. And again, on the slide, you can see some of the metrics related to this program, where we're serving more than 100,000 children that receive physical assessments and health screening, dental screens. Children with identified developmental or other medical issues are serviced in this area, as well as nearly 12,000 infants receive services of remediate developmental delay. The purpose is to avoid some unnecessary health problems later in life by providing comprehensive health services to infants and children in programs such as Babies Can't Wait, Children Medical Services, Infant and Child Oral Health, and Regional Tertiary Care. In this program area, item number 1, again, relates to a reduction in staff positions, or not filling staff positions, of $205,000. Item number 2 is reducing the programmatic grant and aid to counties and boards of health of about $167,000. Number 3 reflects savings from the Babies Born Healthy program, which, as I understand, is being phased out and may already have been phased out, but is significantly down the road in that process. And number 4 is the Regional Tertiary Care Centers contract to amend them to provide for a minimum level of prenatal care services. In the area of infant and child health promotion, we provide education services to promote health and nutrition for infants and children to more than 300,000 women, infants, and children. In the budget area, item number 1 again is the reduction of workforce, holding the vacant positions open, $854,000 related to that. Item number 2, which is on page 26, item 17.12.2, reduce funds for contracts in the amount of $20,000, which are related to childhood cancer research contracts. And item number 3 is to recognize contract savings, again, from moving those hemophilia clients to the PSIP program that I discussed earlier. The next programmatic area relates to inspections and environmental hazard control. As you can see from the metrics there's a lot of things that the department does, from inspecting restaurants and food service programs, tourist accommodations, on-site sewage management, well water supplies, chemical hazards, responding to rabies incidents, and other environmental hazardous complaints. Obviously, the purpose is to detect and prevent environmental hazards, as well as providing an inspection and some enforcement of health regulations in food service establishments and the other areas that we talked about. In the budget category, you can see item number 1 again relates to the discontinuation of the laboratory testing related to well water, I believe is this area, reducing operating expenses, and not filling vacant staff positions. The next area relates to the public health formula grants and aids to county. Funds in this category are distributed to 159 county boards of health. As you can see, it provides about $61 million in state funds to local boards of health in return for delivering basic public health care services. The counties have discretion as to how they spend that money, but it's historically gone to pay for clinic staff salaries and other administrative expenses. The funding ranges from a low of about $48,000 to a high of about $5.6 million, and the average grant is about $362,000. This is a budget reduction in grant in aid of 4%. And you can see that reflected on page 27 in item 17.17.1. Vital Records is another program within the department that maintains records of births and deaths, marriages and divorces, and other data important to Georgians and across the country. In FY 2010, we recorded nearly 135,000 births and nearly 64,000 deaths. Obviously, we share information with the CDC and other branches of the federal and state government to track this important data. In this area on the budget line, you can see we, again, are keeping vacant positions open, reducing that by $97,000. That brings us to the big ones, Medicaid, Peach Care. This is a slide that we showed on Thursday. It's interesting to note that the Medicaid program in Georgia has functioned well in terms of reducing costs per member per year. You can see this graph in FY 2010. You can see that we spent about we had about a 3.7% increase in costs, whereas the national average was about 6.5%. The next slide shows some of the groupings by age. This slide will give you an idea of who our members are. We've got about, between Peach Care and Medicaid, about 1.6, 1.7 almost million Georgians that are serviced by Medicaid and Peach Care. We have about 6%, about 95,000 people, are less than 1 year old. About 22% are children from ages 1 to 5 years old. 40%, the biggest category, are children 6 to 18 years of age. About 23% are adults aged 19 to 64, and about 9% are adults, and the elderly, I guess you'd say elderly is not looking so old these days to me. 65 years of age or older is about 9%. The next slide, I'm sure you're familiar with, just basically shows the growth of managed care in the state of Georgia since managed care was adopted in the low-income Medicaid area. And you can basically just see the growth there over the years. CMO providers, the next graph, again, no surprise here, the market share between the three major CMO providers, WellCare, Peach State, and AmeriGroup, with WellCare having reflected in yellow, having about nearly 50% of the market share, and the other two companies splitting the difference there, with Peach State having a little bit more than AmeriGroup. In the budget document on page 24, item 17.3.1, we reflect the fact that we are reducing stimulus FMAP funds associated with the Medicaid agency expenses, about $10 million this year. That's reflected in there. We also reflect that the reserves of about $46 million, which is related to the IBNR, incurred but not reported expenses that were incurred in FY 2010, but were not paid or will not be paid until FY 2011. In item number 3, there's a transfer of funds from low-income Medicaid, $49 million there, to age, blind, and disabled, and to Peach Care. Total net increase there is about $44 million. Item number 4, we reflect savings from drug company settlements. These are estimated savings that we get. I think it's about 10 million that we get, 11 million that we project. 8.5 million are applied in this particular programmatic area for the age, blind, and disabled. We, in item number 5, reflect about $5 million, $5.5 million in savings from the elimination of some underperforming contracts that have not hit contractual metrics. Item number 7 reflects reduced federal stimulus funds that are replaced with state funds. In the presentation I made the other day, on Thursday, that total number was $131 million. That's been segregated out in this presentation. You can see $69 million in the ABD population, and the rest is reflected in the low-income Medicaid population when we get to that, which is next. Low-income Medicaid. Item number 1, replace the June 2011 Care Management Organization payments. I think this is the capitated payment, I believe, $54 million, so that we can draw down more stimulus funds in this fiscal year. And then we would make that up in next year's budget. Item number 2, this is reflecting that reduced stimulus funding associated with other agencies' Medicaid expenses. That's about $2 million. Item number 3, again, is a swap of funds related to the tobacco money, replacing tobacco settlement funds with general funds in the amount of nearly $12 million. Item number 4 is to reflect reserves of $40 million in Medicaid, which again relates to the incurred but not reported expenses that were incurred in FY 2010 but not paid until FY 2011. Item number 5, transferring funds from low-income Medicaid to the ABD and to Peach Care to align with, I believe it's OPB expenditures, estimated expenditures there. Number 6, reflect projected hospital provider payment collections. This relates to the provider payments that were passed last year. The funding is coming in at a lesser rate than projected by about $13 million, and this budget item reflects current levels of collecting those funds. Item number 7 is again a transfer from low-income Medicaid to fund the finalization of the MMIS system that I discussed earlier. Item number 8 reflects the estimated savings, that's the remaining estimated savings from drug company settlements of about $1.5 million. Item number 9 on page 26, 17.15.9, provides funds to reflect the revised policies in the Patient Protection and Affordable Care Act, the National Health Reform Bill, that reduces fee-for-service Medicaid rebates. That's nearly $10 million there. And item number 10 reflects the reduced federal stimulus funds and replaced with state funds. That's the other part of the replacing the stimulus funds with state funds that I discussed earlier. $61 million in that portion. Which brings us to Peach Care. Peach Care is a program for low-income children primarily. The benefits are the same as the Medicaid benefits, so you'll see similar reductions that were included in the Medicaid budget as it relates to Peach Care. Item number 1 is the IBNR related to Peach Care of about $239,000. Item number 2 is a transfer of funds from low-income Medicaid to Peach Care. This is the corresponding reflection from the other budget items discussed earlier. Item number 3, replace the care management organization payments to maximize federal participation in the CMO payments. That's about $6.5 million. This offsets the reduction, I believe, in the Medicare federal rebates. Item number 4 provides funds to reflect the revised policies in the National Health Reform Bill, and that reflects the Medicaid rebates of $6.5 million. And that brings us then to the State Health Benefit Plan. This is a very important plan to all the state employees. We provide coverage to nearly 700,000 people. And the majority of plan members are state employees, primarily teachers, I think is the largest category, school personnel, bus drivers, cafeteria workers, and their dependents. The audited FY 2010 reserve balance, as I mentioned the other day, is only about $17 million, which provides a cushion of about 2 days of average claims for that program. On the budget portion, if you look at item number 1, which is page 27, item 17.18.1, we recognize the revenue generated from employees with dependents up to age 26 of about $36 million. Those are additional premiums that are collected for covering those younger adults. Item number 2 is the increase per member per month billing for non-certified school service personnel from $162 to $218 per year. Per month. Represents an increase to school districts for their non-certified employees who are enrolled in the State Health Benefit Plan. This formula hasn't changed since the year 2000, and so we're looking for an increase in that in this budget year. The DCH board did approve this increase back in December of 2010. Item number 3 reflects the updated revenue and expense projections related to the State Health Benefit Plan. Item number 4 reflects the depletion of prior year's service of $43 million. The governor's adjusted 2011 budget adjusts for prior year reserves, and it reflects that the audited reserves for FY 2010 in the amount of $17 million. Item number 5 reflects the projected reimbursement available through the Early Retirement Reinsurance Program, which is another component of the National Health Reform Law. That's about a $70 million increase related to that particular provision. Item number 6 reflects the projected cost of changes to coverage of dependent children by the federal health reform. This is the flip side. This would be the, I believe this is the premiums collected for those people being covered that are between 18 and 26. Item number 7 reflects the projected cost of the federal health care to cover 100% of the preventative coverage as defined by the National Health Reform Law of about $5 million. Item number 8 reflects an increase in the state appropriation to the Department of Education so that they can pay the increased premium I discussed earlier for non-certified school service personnel benefit expenses, $56 million there. Item number 9, increase in funds related to the surcharge, spousal and tobacco surcharges in the State Health Benefit Plan. I believe we increased those by $10 and $20. Item number 10 reflects the reduction in the employee premium revenue due to the elimination of the open access plan in the state health benefit. So we collect fewer premiums by elimination of that plan. And then we also reduce expenses by eliminating the open access plan in item number 11 by $110 million. That concludes my walkthrough of the BCH budget, and be happy to answer any questions that you may have.
I think we've got a few.
But
Chairman Snell has a question for you.
Thank you, Mr. Chairman. Commissioner, welcome. Look forward to working with you.
Thank you.
On your PowerPoint, slide 15 and 16, having to do with healthcare facility regulation.
Yes,
about this time last year, your predecessor suggested to this committee that one of the ways to get caught up on the backlog of facility regulation and credentialing and all that sort of thing, we're having major problems in terms of how long it took to get credentialed and for new facilities to get inspected. And some of these facilities would be brand new, sitting there ready to go, ready to hire people and put them to work. But the department couldn't get caught up and on time. And as a result of that, this committee and this General Assembly allocated $478,000 to hire 6 folks. That's what the department told this committee and the General Assembly that it would take to fix it. My question to you is, this money being deleted, has the problem been fixed? Is it a waiting list now, or are we current, or what's to do?
Well, let me just say, if I can answer that in a broader global perspective, there are certainly budget constraints that everybody's well familiar with. I am concerned that we're having difficulty getting nurses and others to, and the salary levels that we pay in state government to do the job that we need to do. But the budget realities are the budget realities. I will ask Leslie Poole if she can give us an update as to where we stand in terms of a backlog in inspection and certifying those facilities, if that's all right.
Is this on?
I believe so.
Mr. Chairman, members of the committee will happily respond to that. What was done last year, these additional positions, 100% state funded, were appropriated, and at the beginning of that fiscal year, we were asked to project an additional 6, 8, 10% cut in state funds. It's my understanding that the decision was made to attempt to improve these processes and get rid of these backlogs with existing personnel, as most of our other personnel are funded primarily with federal funds. And if we tried to project another cut for those percentages in purely state funds of 90% of our personal services, 90% of our state funds are personal services, it would result in having to hold vacant 4 or 5 times that number of positions other than those fully state-funded positions. And it's my understanding that decision was made currently, and the answer to your question is that it was primarily a problem with ambulatory surgery centers, as I recall, the processing of those applications. We currently have no backlog in those applications. We've completely caught up with those applications. And we don't really have outstanding backlogs in our other department programs either with applications. Some of those processes are lengthier processes than others in terms of particularly hospice and some of the other application programs. It does take about 60 days back and forth between the department and applicants usually to get those resolved. But it's my understanding that we're not exceeding those deadlines at this time.
Mr. Chairman, your permission, one follow-up. While this doesn't relate 100% to facility regulations, it really was tied into the regulatory and licensing program. So for example, physician credentialing, how long does it take to get credentialed now?
I don't have the answer to that question. The Medical Composite Board does...
No, I'm talking about from the CMO standpoint.
CMO?
Jerry
I don't have that
Deverly, if I could
information.
ask him to comment.
I mean, because all this was tied into that. It was problems with facilities themselves, and it was also problems with actually getting credentialed. I can't remember what the number of days or months it is, but after so long, those docs can't even bill the thing. And I just want to know an update on where we are with that.
Sure. With these positions, again, these are for facility regulation and facility licensing. On the CMO side, and you ask about the physicians, about 45 days is what it takes to credential a physician. Now, I will need to caveat that by saying that the CMOs require that they be enrolled in Medicaid first. So I think that is the area where that some of the delays are seen. With moving to our new fiscal agent, HP, we've shortened the performance standards for the work that has to be done there down to 15 days. So we are starting to see some improvements there. Provider enrollment doesn't actually fall under my unit, so I don't have the exact numbers, but we can provide that as a follow-up.
Thank you.
Okay, Representative Henson.
Thank you. I wanted to follow up on the credentialing. And I do have a question. There have been changes with the CMOs that they'll change names or they'll.
But that's very different than a recredentialing. So this is the first I've heard of a multi-year credentialing process. So I would be glad to follow up on that.
You know, I will follow up and find out if it's recredentialing or what was the other word used?
Recontracting. I know we have a change in dental subcontractors for one of the CMOs, and so recently they have been working to recontract their network.
I'd love to talk to you about that another time. May I ask another question, please, Mr.
Sure.
Chairman? Totally different. On the hemophilia patients, we're taking the money out, and you said because of the move to the PCIP plan. When does that go into effect?
I believe it's in effect now.
Good.
And
So there's no
currently
lapse
being
in.
migrated over. To the
So there's no lapse in coverage.
Correct. That's my understanding.
Okay. Public health. We talk about epidemiology. What else? You know, when I was growing up and sort of thought that public health is being place that folks that didn't have enough money to go to the doctor or didn't have coverage could go more on a sliding scale or something. Are we phasing that part of it out and just doing more epidemiology and tracking things? I mean, is public health going to remain in a provider-type service?
Public health has certainly had its share of challenges recently. I'm anxious to get in and look at that program, to work with it, and I believe that we need to really take a hard look at where we are focused in public health. I know the public health district directors came up with a strategic plan that had 4 areas of focus related to immunizations and obesity, and I can't recall the other 2 areas, but I believe given our current circumstances, we're going to need to improve how the program operates and make sure that its focus is streamlined.
I'd really like to see that. I think it's important. I think it serves a very, very important role. Another question.
If you would, Representative, make it sort of short. We've got several others that have questions. We only have about 10 minutes. We want to try to get around everybody. If
Adult
you would, please.
daycare licensing. Is anyone licensing them?
I think that is, if I'm not mistaken, that's an area where we haven't even begun doing that. Have we done that?
I don't know if we've begun. I know that if we have, my understanding is if the funding is not there, then we don't provide that service. And so this does deplete that funding. So,
thank you.
The statutory language to begin adult day licensing by healthcare facility regulation passed a couple of years ago. We went through a rules development process for that, there was a lot of negotiation about the rules, and about the time that we were about to approach the DHR board with the final rules for adult day licensing is when the severe budget constraints struck. And the decision was made at that time not to open a new program at the time that we were suffering those budget constraints, and those final rules rules were never vetted for that program. So, but at this time, really, most of the adult day oversight comes from the Division of Aging at this time, and there are programs through the Division of Aging to provide oversight currently for most of the adult day health programs and those programs that require more significant oversight.
So there is some oversight.
There is some oversight.
That's
yes,
what I was very, very concerned about.
Okay, Representative Gardner has a question.
Thank you very much, Mr. Chairman. I'm not sure who will answer this question. I guess the commissioner gets to answer them all. I'm concerned about the waiting list for people with AIDS. It's been brought to my attention that the waiting list now in Georgia is the second largest in the country, and I'm grateful that we have not had a cut in the ADAP funding. But I am concerned about the growing waiting list and wondered what ideas, is there an opportunity to apply for any federal funding, a Medicaid waiver? Have you done an analysis of what we could do to try to bring down some more dollars for treatment, not just for people with full-blown AIDS, but also with people who are HIV positive? So perhaps if you would provide me with that information when you get it, I'd appreciate it. A couple more quick questions, Mr. Chairman, if I can. Throughout the document, there are places where you show us the impact that the Affordable Care Act has had on our state in terms of various kinds of income and various kinds of additional expenditures that are required by the Act. Would it be possible for you to put together an analysis of where it's been helpful and where you feel like it's costing us additional dollars so that we would have a real understanding of the impact on our state at this point and looking forward? I guess that's all.
Okay. Representative Shelton has a question.
Thank you. We'll look forward to working with you. Very excited you're there.
Likewise. Thank you.
Although very challenging times. I just have a couple of questions. I know, one, there are several places in the budget where you talk about discontinuing lab testing, specifically for well water, AIDS testing, and there was one more, I forget what. Fluoride. Okay. So if we're going to discontinue lab testing, who exactly will be picking that up?
It's my understanding that the private sector provides these tests, and those that are interested in getting the test can access those private facilities to do that.
Okay. And do we currently charge, I guess in the past, have we charged citizens for those tests?
I think we probably do.
Okay.
Pardon me?
They pay directly to the private provider?
They will now?
Yeah.
Okay.
Just go out in the marketplace and get it.
Okay. And I have another question. I know in public health, I'm excited about, it's kind of finally looking at it and kind of consolidating the mission statement. I think that's definitely the first step. But I'm definitely concerned about the cuts that we've seen to public health funding over the past several years. It seems to have been a cumulative thing. So it's definitely very concerned about where we're heading on public health. So, and I know there are several different locations in this budget, and I probably go through it myself, but if you could kind of give us a cumulative total of the cuts that public health will be receiving. Yeah, county by county would be definitely nice. And the grant and aid, especially reduction in. Okay, great. I forgot we have Margie. But
thank you.
Thank you. And you get that to me? Okay.
Okay, we got time for about one more question. Or not. Okay. Yeah. Doctor, let's see, number 17. Okay.
Thank you, Chairman. I'll be real brief. Commissioner Cook, look forward to working with you. But I'm obviously very new to this, but I'm looking at the replacement of the stimulus funds in the low-income Medicaid and in the aged, blind, and disabled. Now, notice those we had a % change of increase, but if you take into consideration the replacement of the stimulus funds, it looks like those actually go down. So we're actually having a reduction in Medicaid funding, correct?
I believe that's correct. Yes.
by replacing the stimulus funds. Okay, that's all.
Commissioner, thank you and your department for coming today and presenting, and to all the others who presented. We appreciate you being here, and to all of you who are interested and visited with us today, we're glad to have you, and the meeting is adjourned.